All right, today we're going to talk about something a little different. Not so much a disease, but a real surgical crisis. A high-stakes problem that pops up when the body's internal plumbing springs a really catastrophic leak. We're diving into chylothorax and how some new science is completely rewriting the playbook for how we fix it. Okay, so picture this. You've got this superhighway inside your chest called the thoracic duct, but it's not carrying cars, it's carrying something way more precious, chyle. This is a super nutrient-rich fluid, and it's packed with fats, proteins, and the immune system's frontline soldiers, the T lymphocytes. So when this highway breaks, which often happens after a big surgery like an esophagectomy, man, it's not just a leak, it's a critical drain of the body's most essential stuff. And believe me, this drain is fast. I mean, we're talking about losing up to 4 liters of this vital fluid every single day. Can you imagine? So your body is literally just hemorrhaging its immune cells, which, opens you up to all kinds of severe infections. It's losing the proteins it needs for your blood to clot. It's being stripped of essential electrolytes. This isn't some slow drip, it's a full-blown metabolic crisis, and the clock is absolutely ticking. So, okay, how have surgeons typically dealt with this mess? Well, for years, there's been this pretty standard playbook, a kind of a consensus, step-by-step guide that everyone follows. And the whole idea is to start with the least invasive options first. Yeah, it's basically a 3-step process. So, step 1, you try to slow things down conservatively. We're talking special diets, IV nutrition, that kind of thing, for about a week. If that doesn't do the trick, you move on to phase 2, interventional radiology. Here, a radiologist tries to thread a catheter through your body's vessels to plug the leak from the inside. And only if that fails do you finally move on to the last resort, surgery, to go in and actually tie the duct off. Sounds logical, right? You start small and you only escalate if you have to. But here's the kicker. What if that logic, as sensible as it sounds, isn't actually the best thing for the patient? What if all that waiting and following those steps actually leads to worse outcomes? Because a really powerful new study has just come out and basically thrown a grenade right into the middle of this whole established playbook. And this really forces you to ask a tough question. When you're dealing with one of these massive, high-output leaks, is waiting around for that last resort option actually the riskiest thing you can do? So, this 2025 meta-analysis decided to put phase 2 and phase 3 in a head-to-head matchup. Researchers looked at patients who got the standard interventional radiology procedure and compared them to patients who got surgery early on. And let me tell you, the results, they didn't just nudge the needle, they pretty much snapped it in half. Okay, check this out. An odds ratio of 6.13. What does that even mean? It means your chance of actually fixing the leak on the first go was more than 6 times higher if you went straight to surgery compared to the radiology procedure. I mean, wow. That's not a small difference, that's huge. And it's not just about getting it right the first time either. The ripple effect from this is massive. Patients who had surgery first went home on average almost 15 days sooner. That's 2 whole weeks less time stuck in a hospital. Think about what that means. Lower costs and getting people back to their lives so much faster. The data is just crystal clear. Getting it right the first time really, really matters. This quote right here, it just nails the new way of thinking. It's what we call a consultant pearl, just a little nugget of wisdom. Basically, if your patient is healthy enough for an operation and they have a massive leak, we're talking over a liter a day, the data is screaming that you should just skip step 2 and go right to surgery. Waiting around for a procedure that has a high chance of failing just isn't the best option anymore. All right, so you're probably wondering, how in the world are surgeons pulling off a success rate of over 95% on something this tricky? Well, the answer isn't just about having steadier hands. It's about having better eyes. We're talking about a high-tech way to see what's normally invisible. The real game changer here is this special dye called indocyanine green, or ICG for short. The magic happens when you look at it with a near-infrared camera. This stuff just lights up, glowing a super bright green. And this isn't some experimental thing anymore. This has quickly become the absolute gold standard for these kinds of operations. It lets surgeons see the entire lymphatic system in real time. Okay, so here's how it actually works in the OR. First, a little bit of this ICG dye gets injected into some lymph nodes down in the groin. The dye travels up through the body's lymphatic system. Then, the surgeon flips on this special camera and bam, the whole thoracic duct is glowing green on the screen. Suddenly, finding the leak isn't guesswork. It's like a glowing beacon saying, hey, the problem's right here. The The surgeon can go in, tie it off with incredible precision, and then they'll watch for 5 or 10 minutes just to make sure the glow has stopped and that there are no other sneaky little leaks hiding nearby. So this is what the surgeon is actually looking at on their screen. It's pretty amazing. On one side, you've got a healthy duct. See how it looks like a nice, clean, sharp green line? A perfect little highway. But then you look at the other side, where the leak is. It's not a line anymore. It's this hazy, cloudy green mess. There's zero guesswork. The ICG gives you a glowing roadmap right to the problem. Okay, so does all this new data mean we just take the old playbook and toss it in the trash? No, not at all. What it really means is that our playbook just got a serious upgrade. It's become way more intelligent, way more nuanced. We're stepping into an era of real precision. And I really want to be clear here. This isn't about saying surgery is always the better option. If you have a patient who's just not a good candidate for surgery, or if the leak is pretty small, that traditional step-by-step approach might still be exactly the right call. What this new evidence does is it gives surgeons the confidence and the data to make a different, more decisive call for a very specific group of patients. And for them, acting fast makes all the difference. This table really lays it all out. You can see that TDE, the radiology procedure, is still a totally solid option for smaller leaks, with a success rate that can get up to 80%. But for those big, high-output leaks, man, look at that. ICG-guided surgery is hitting over 95% success with a much, much lower chance of the problem coming back. It really just depends on the clinical situation in front of you. So when you boil it all down, it really comes back to one thing. Look, medicine is always changing, always evolving. And when some really powerful new evidence comes along and challenges the rules we've been following for years, well, the surgeon's ability to think, to adapt, and to make the right call for the one single patient right in front of them, that becomes the most powerful tool in the entire room.